Alrighty, we can go ahead and get going. Thanks for coming tonight. Let me share my screen real quick. There it is. Slideshow from beginning. Okay, can everybody see that? Yay, great, awesome. Yeah, so today we're talking about hematuria. So I know a few people had mentioned wanting to do like GI related stuff, so that's maybe what I'll focus on in a couple weeks. I was on my urology rotation the past couple weeks, so I was like, this is pertinent to what I was studying, so I thought it might be interesting to you as well. Also, which hematuria means like blood in the urine, heme and then urea. It means blood in the urine. And no matter, what specialty you're going into, hematuria can be a, primary care problem. Whereas like old elderly individuals might come to your clinic and have concerns with blood in their urine. If you're in peds, it could be a concern. If you're in internal medicine, you'll probably see it. Urology, obviously, nephrology. So a lot of things in the future, a lot of patients that you have, you might see somebody come in with this complaint. So I wanted to develop like a framework for how do you work up somebody that comes in with concern for blood in their urine. And yeah, so let's get started. So yeah, if you guys don't have access to the link, let me know. You can fill out the SOAP note throughout the presentation, either on the Google Doc, or you can just like take notes on your own, or you don't have to, whatever works best for you. So let's get started with the case, and we'll, walk through this. So you have a 59-year-old male. He comes to his primary care physician, or he comes to you with concerns of 5 episodes of bloody urine in the past 3 weeks. His most recent episode was this morning, which is what prompted him to come into your clinic. He does have some mild pain with urination, and that's been going on for 1 week, but no other symptoms or concerns. He has a past medical history for hypertension, and he takes 10 milligrams of lisinopril daily. He had a tonsillectomy as a child, but otherwise no surgeries, no family history of cancer. He has a 35-pack-year smoking history, and he quit 10 years ago. He drinks alcohol socially. He's a retired history teacher, and he lives with his wife in Iowa City, and they have 3 children. So what other history do you guys want to know? We'll look at the physical exam first, because I know that that's something everybody always asks for when I say, what more do you want to know? So yeah, you guys did a physical exam, and you can see here that vitals look pretty stable overall, generally normal. His abdomen is soft and non-tender without guarding or rigidity. There is some mild tenderness to palpation of the suprapubic area, but otherwise he doesn't have any flank pain. His scrotum is not swollen or red at all, and neurologically intact. His mood and affect are appropriate, and MSK is grossly normal. So do you guys have any questions that you want to be asking this patient? And I can come back to the HPI. Ignore my email. Okay, I think we've got a smoker. Yeah, so he has a 35-pack-year smoking history. Great, that's always important. Anything else that we want to know about him? Let me ask you this. When you're thinking about somebody, recent infections is what Adam said. Why are you going to ask him about recent infections? UTI, yeah, absolutely. A urinary tract infection is something that would be on our differential. So yeah, if somebody's coming in with blood in their urine, what kind of things are we thinking of? What kind of things are we concerned about? What could be the possible causes of blood in the urine? So Adam already mentioned one, UTI, so we want to make sure we ask about recent infections, fevers, pain with urination. He has a little bit of that. Urinary urgency and frequency, all of those UTI symptoms. Internal bleeding is one. So yeah, maybe asking him if he has trauma. Kidneys, yeah, that's a huge one. Yeah, thanks, Diana. That's a great one to ask. So maybe asking, do you have a family history of kidney disease? Do you yourself have kidney disease? Things like that. Anything else that you guys can think of? This is a pretty good start for like a framework, right? Like trauma, UTI and urinary stuff, and then potentially kidneys. So we can go ahead and go on to the next slide. So here's where I kind of laid out some important questions to ask when you have somebody comes in with a chief complaint or concern of blood in their urine. And all of these questions, as always, your history questions, you're going to narrow them down and pick questions that are related to the differential diagnosis that you're making in your brain. So you're thinking of all the things that you're concerned about that could be causing hematuria, and you're asking the questions related to them. So again, any trauma, Adam had mentioned internal bleeding, UTI, so ask about UTI symptoms, which would be like flank pain, fever, urinary symptoms. Has he had a UTI before? Urinating at night. This is a 59-year-old male, so we could have something called benign prostatic hyperplasia. I don't know if you guys have heard about that at all, but the prostate, if you think about it, it's like a little circle, it's like a sphere. And in the middle of it runs the urethra, right? In the middle of it runs the urethra and connects, the bladder, prostate to the penis. And around that urethra area, as you age, as men get older, you can have hypertrophy or basically an increase in cell size around that middle portion, not around the outside, but around the middle portion. It spans out like that. And what that can do is that can cause symptoms of like needing to get up and go to the bathroom a lot during the night. It's also a common cause of hematuria. So that's an important thing to ask this patient. You could even just, ask him, have you ever been told you have a large prostate? Or do you take any medications for BPH or have been diagnosed with that? More to ask, any occupational exposures to like dyes or amines, or have you had chemotherapy or radiation? Here we're more getting like at the risk of bladder cancer. Because obviously that's a concern of ours when somebody's having blood in their urine. Is that coming from the bladder? Do they have the tumor? Do they have cancer? Same for like kidney cancer. One that's interesting that can cause a certain type of bladder cancer, one of the less common causes of bladder cancer, is a schistosoma infection. So asking them if, and we're not going to go into detail about that, but asking them if they have traveled outside of the country or if they've lived outside of the country could be important. History of kidney stones. Diana had mentioned kidney involvement, and that's important too. Any history of leg swelling, puffiness under eyes, frothy urine, hypertension. We know he has hypertension, hearing loss, sinus issues. All of these are related to glomerular diseases. So I'll wait to chat about that because we get to that on the next slide. Family history, again, of cancers, medications. So you guys did a good job at an overview of some of the things you'd be concerned about. So does anybody have an idea of, maybe the first best step in what we would do for initially evaluating this patient? So he's coming in and blood in the urine. So are there any tests that we want to do at first, just to give us a, first step type of thing and to rule out, one of the things you guys are worried about? Yeah, look at the urine. Yeah, exactly. So good. Yeah, an easy test to do would be a urinalysis. Because again, one of the things we're worried about is, or one of the things this could possibly be, is a urinary tract infection. And I will go through what a urinalysis shows on the next slide, I believe. So yeah, we could do a urinalysis. With an examination of the sample. I mean, obviously, if there's gross blood within the urine, we could just simply like look at the toilet, but that's not always the case. A urine dipstick and a microscopy, which is when we like spin down. Oh, I think somebody has a UA with micro. Yeah, exactly. Yeah, Diana, that is what it's called. And microscopy is like when we spin down the sample and it separates into the certain cells. And so you can see like how much cells are within the specimen. So for example, like how many red blood cells, or if there's any white blood cells, how many of those. Additionally, you could throw in a culture if you are concerned that this patient has an infection. And what that does is just specify what kind of bacteria is causing the infection. But that's not always necessary, especially if like somebody's coming in without complaints or concerns of a UTI, but it's something to consider. All right, so let's talk a little bit more about hematuria and like a framework, because again, I think this is a common, complaint that you might see in primary care settings. And so knowing how to go about like differentiating the common causes and the workup for things is really important. Okay, and so we're going to talk about, so gross hematuria is when it's visible to the naked eye. So it's when you have gone to the bathroom and you see red in the toilet, you see blood with your eyes visible. Microscopic is when you've done some, a urinalysis for some reason. Maybe you have, it's an older woman, she's got some urinary frequency and you want to make sure she doesn't have a UTI. And you do the urinalysis and you look, and on my microscopy, they see red blood cells. That's something that's incidentally found, right? Because you can't really see it. You can't actually see it within the toilet gross with your own eyes. So that's what microscopic hematuria is called. So broadly speaking, the way that I think about hematuria, and a lot of people think about hematuria, is that you separate it into glomerular and non-glomerular diseases. And so what do I mean by that? So we had mentioned on the previous slide that with hematuria, a concern might be the kidney, okay? And if anybody, I don't know if you guys remember, but the kidney is like the main functional anatomical unit you think of when you think of the kidney is the glomerulus, right? It's like the filter. It's like the blood vessels that are leading into the kidney and that are filtering waste, reabsorbing things. It's all at the glomerulus is where that starts, that whole process starts. And for the sake of time, obviously not going into all of renal physiology, that would take an entire lecture, if not more. But I think the idea here is if there is damage to the glomerulus, even though it's so tiny, there's just like millions, I think, of glomeruli within one kidney itself. If there's damage to that, such that like the basement membrane of those blood vessels are like leaky and they break, essentially, you can have leakage of red blood cells into the urine, right? So really, when we have a kidney problem causing hematuria, we're really looking at the glomerulus and we're saying, is there something wrong with the structure and the anatomy of the glomerulus? Is there something wrong with that? So that's glomerular disease. So that's what you have on one hand. Two, you have non-glomerular causes, so non-kidney causes. So those could be menstruation. I mean, obviously, when women are menstruating, you can see gross hematuria, UTIs, kidney stones, bladder infections. Malignancy is one we're obviously worried about. That renal cell carcinoma, bladder cancer, prostate cancer, and then trauma. So that's kind of what you want to do. So the urinalysis is a great way to start and a great way to split up what's going on, because if on your urinalysis you have something called proteinuria, which is protein in your urine, and if you have dysmorphic red blood cells or red blood cell casts, that indicates that you probably have a kidney problem. And why is that? That's because when there's a problem with the glomerulus and red blood cells are getting leaked into the urine, what happens is when they're traveling down and from the kidney through the ureters and everything like that, they form these little casts, right? They look weird and they look dysmorphic. And so when they spill out into the urine and you look at it under the microscope, you can see those dysmorphic cells and those weird shapes. And so that points you to the kidney is probably an issue. And why protein? Well, obviously, if we have leaky glomeruli and we have filtration and everything like that is compromised in the kidney, then you can have protein leaking into the urine. So those are the two things to look for to tell you, I think something's going on with the kidney, okay? So again, initial workup of hematuria, you want to do a urinalysis with microscopy, and that's helpful because that can rule out a UTI. It can also tell us, is this like something we need to look at in the kidney? Something you can do is called a dipstick, and this is what this shows up here. You need to be, and you can look to see basically if this has, if the urine has red blood cells in it. The problem with this is there can be false positives. If you're exercising a lot, if you're dehydrated, if someone's menstruating, if they have something called rhabdomyolysis, I can't ever say that, that can cause false positives on dipsticks. So anytime you do a dipstick and it's positive, you need to follow it up with a urinalysis and microscopy anyway. Okay. So let's go back to our guy. So he did a urinalysis with a microscopy and the results return, and it shows greater than 50 red blood cells per high-powered field. So essentially under the microscope, they're seeing a ton of red blood cells in this guy's urine. They don't see any dysmorphic red blood cell casts or red blood cells, dysmorphic red blood cells or red blood cell casts, and the culture is negative. So until we go to the next, before we go to the next question, let me ask you, do you think this is like a kidney problem or do you think this is like a non-glomerular problem? Kidney problem. Okay. Let's go back real quick. Or no, I think we just read this. So no dysmorphic red blood cell or red blood cell cast. So maybe you just had that part confused. So no dysmorphic red blood cell or red blood cell counts points away from a kidney. If it was a kidney issue, you probably see dysmorphic red blood cell or red blood cell cast, or at least you'd be concerned that a kidney issue would be going on in that case. But great job. Yeah, non-kidney because no cast. Yeah, great. And then what about a UTI? Do you guys think this guy has a urinary tract infection? And again, don't hesitate to participate. It's fine if you get things wrong, we're all here to learn. We all have different backgrounds. Yeah, probably not. And again, that's because the urine culture is negative. Also, we don't see, I didn't mention any white blood cells in the urine or any of those enzymes that bacteria produce, like leukocyte esterase and nitrates. So yeah, this guy doesn't have a UTI and it doesn't seem like this is a kidney problem. It seems like it's non-glomerular. So what's the next best step in management? And I don't expect people to know this, but I guess big picture thinking, we've looked at the urine. And if we go back to our differential for non-glomerular causes, so menstruation, this is obviously a man, kidney stones, malignancy, trauma, is there anything you would want to do to check for some of these? Bladder scan or ultrasound, x-ray, great, yeah. Thinking of imaging, wonderful. Yes, imaging in general. I think big picture is, yeah, great. You guys are totally on the ball. Imaging is where you want to go. So yeah, so we want to image the urinary tract, right? So now we know that it's probably not the kidneys, but it could be anywhere along the urinary system that this patient is bleeding and then there's blood leaking into the urine. So how do we image the urinary tract? Well, you have to image both the upper tract and the lower tract. To examine the upper tract, you do something called a multiphasic contrasted CT scan. So essentially a CT scan with contrast. And that helps show you the upper urinary tract, and we'll talk about that in the coming slides. So that tells you what's going on in the upper urinary tract. And then a cystoscopy is what you're going to do to evaluate the lower urinary tract or the bladder. And I'll show you a picture of that as well. It's taking a scope and going through the penis and the urethra into the bladder and looking and seeing, is there any pathology in there? Are there any noticeable tumors? Things like that. Let's pause though first, because I want to distinguish between gross hematuria and microscopic hematuria. I know I had gone over that before, and I know you guys are aware that gross is where you can see it in the urine, and microscopic is where, you know, it just shows up on your analysis. But the workup tends to be pretty much the same, because it's all based on risk stratification. So I want you to imagine that, again, let's think of like a female, an older female patient, and she's coming in because she has urinary urgency, and you're an astute physician and you say, I wonder if she has a UTI, so I'm going to do a urinalysis. You do that, doesn't show a UTI, but you happen to see that there's red blood cells in her urine, which is an incidental finding, obviously. And you're like, okay, well, I need to work this up. If there's more than 3 red blood cells on a urinalysis, you need to proceed with like further evaluation. And so what you would do in that case then is you would risk stratify the person. So what we do for risk stratification is basically looking at age, looking at smoking, looking at how many red blood cells that you see on high power fields on that microscopy, and then additional factors as well. And what that does is that will tell us, okay, well, what kind of imaging do we have to do? Do we have to do this multiphasic CT, the CT urogram and a cystoscopy, or can we get by with just a cystoscopy and a renal ultrasound, or just, you know, maybe repeating everything in 6 months? So basically, risk stratification is big. For our patient, he had greater than 50 red blood cells on urine microscopy, which is gross hematuria. And you can see that automatically puts him in the high risk category. So we're automatically doing the cystoscopy and the CT urogram. Had he had microscopic hematuria where he wasn't seeing it, but on like microscopy, we saw maybe 4 red blood cells or something, he would still fall into this category because he's had 35 pack years of smoking. Right. So that's where it's important to think about all of the risk factors and such. And this is kind of the algorithm of how you would work a patient up when they come in with, you know, either gross hematuria or microscopic. So from that, essentially, I wanted to make a point that all patients with gross hematuria who come in and see blood in their urine, they require the highest, you know, risk evaluation. So they require imaging with the upper urinary tract, which is a CT urography or the multiphasic CT scan, and the cystoscopy, because they're automatically at high risk, right? Greater than 25 red blood cells per high power field. That's going to be, you know, greater than 25, you're probably going to be seeing the blood grossly. So quickly, what's a CT urogram? It's an imaging that allows, again, like I said, visualization of the entire upper urinary tract. They do it in different phases. So like there's a non-contrast phase where they take pictures, then they administer the contrast, and then they wait and they take pictures for the delayed phase. And each of the phases tells us something different. I don't really know this. I mean, it's not necessarily important unless you're like really interested in like radiology to know this. I think that the big thing is that this is the test you would order. So knowing what test to order is important. And one thing too is that if you have a patient who has like kidney disease and you're worried about giving them contrast and, you know, for the CT scan, you can consider doing an MRI. But if the GFR, so for example, their chronic kidney disease is not terrible, you can still pre-treat them with like normal saline or something, and that helps avoid some of that nephrotoxicity or the toxicity to the kidney from going through the CT scan with contrast. But even that, I mean, the reason that people with chronic kidney disease are not supposed to be administered contrast is because you can get like this nephrogenic fibrosis type of thing. But that's only occurred in like a small number of cases. So it's kind of interesting that we have made this, criteria or recommendation to avoid contrast in all patients with CKD, because the evidence doesn't really show that it happens much. So anyway, that's just a side note. But okay, moving back to our patient. So our patient's CT urogram, you can see here, this is obviously an image of the pelvis. This here is the bladder, okay? And does anybody, well, I guess you guys don't have access to the pointer, but do you guys see anything that you're concerned about in the bladder? Could you maybe tell me? Oh, I guess I wrote it on this slide. I'm so sorry. But yeah, this is the tumor right here. We're concerned that this has this obviously is not normal. We shouldn't be finding this tumor projecting into the bladder. Notably right here is the rectum. Just to kind of orient you a little bit. And this is obviously looking at the feet. Otherwise unremarkable, okay? So his CT urogram just shows this tumor here, and then everything else was normal. So what's the next best step? And you guys might know this because we kind of talked about the two things you would need to do if somebody has gross hematuria. So we've looked at the upper tract. We see that, there's a concern for a tumor. What else do we need to do? Biopsy the tumor. Yes, we absolutely are going to have to do that. But do you guys remember how you would look at the lower urinary tract? So even though this was looking at the upper urinary tract, of course, yes, we did see the bladder, which is part of the urinary tract, lower urinary tract on this scan, but this scan was mostly to look at the upper urinary tract, and we saw that there were no problems with that. So how do we look at the lower urinary tract? Yes, like an endoscope. Yes, a cystoscopy. Yep, it's like a scope that goes in to look at the inside the bladder. So great, and that's also, as Adam pointed out, like a biopsy. That's also how we biopsy the tumor, even remove it at that time so that pathology can look at it. Okay, yep, cystoscopy. Again, we needed to do the upper and the lower tract. Okay, so this is actually, I think, labeled wrong. This is a little bit different than what a cystoscope looks like. I think this is for the actual procedure that we'll talk about in a little bit, but just imagine it's pretty much the same. I just to be consistent and everything like that, I just wanted to point that out, that this is probably not exactly what a cystoscope looks like. But generally, this is what the scope is going to look like. And you go through the urethra, the penis, and you go into the bladder here, and then you can see, obviously, the inside. And so in our patient, what we saw was a small little papillary tumor. So what do we want to do with that? We see it, we've got our cystoscopy, we're in that, we've kind of already set it. But what do we want to do now that we're in there and we can see the tumor? Do we want to just leave it and then forget about it, maybe look at it in a year or two? Yeah, get a sample. Yeah, so what we do is something called transurethral resection of the bladder tumor. It's fancy, it's called TURBT. It's really similar to cystoscopy, but it uses a resection scope. Again, so I think this is what the resection scope looks like, if I'm not incorrect. But yeah, very similar to cystoscopy. They're pretty much the same. You do the same thing. You go in there, but this time, it has something that's able to resect the tumor. Now, the TURBT procedure is both therapeutic and diagnostic because we can remove the whole tumor at the same time. So we don't necessarily have to just biopsy it and leave the rest in there. We can just remove the whole thing, and then we can send that off to pathology. So in that way, it helps us diagnose what's going on. And two, it's also therapeutic because you're removing the tumor. And so these are just some pictures of inside from the the view of the like cystoscope or the resection scope, where you can see this tumor here, and then you've removed it and you have like this granulation tissue starting to form. Like basically the what they do is they use fulguration. So they use like almost like electrocautery to dissolve some of that tissue. And what that does is it helps, make sure that you haven't like left anything behind. I mean, obviously you aren't certain every time, like you take as much as you need, but this helps a little bit to make sure like that some of the things that some of the cells that we might have missed are fulgurated. So that's what that looks like, kind of interesting. So just an overview, learning points for bladder cancer. Bladder cancer, it's more common in men than women. I thought that was interesting. I didn't know that until I was learning about this. The average age is 73. 90% of people are greater than 55. So again, our guy was like 59, I think. There's 81,180 new cases of bladder cancer a year. So that's a lot of people, right? And it has a low death rate, but a high recurrence rate. And we'll talk about why bladder cancer tends to recur even after you treat, the first tumor or whatnot. White people are more likely to be diagnosed than African Americans or Hispanic Americans. And the most common chief complaint of somebody who has an underlying bladder cancer is hematuria. So again, that's why you have to be very thorough with that workup. Even if somebody like that example of the female coming in, concerned for UTI. We did the urinalysis, no UTI, but we did see red blood cells. That's why we have to work that up, right? We can't just let that go because, that could be bladder cancer. And so, yeah, that's just an important takeaway, I think, from this session tonight. Some risk factors, cigarette smoking is a big one. Again, anytime you like irritate the epithelium in the wall of the bladder and you expose it to like carcinogens, obviously you're going to increase the risk of cancer. Other things as well, as I said, like chemotherapy, any occupational exposure with like dyes, people that work in like textile industries, things like that can be a risk factor. So having a thorough history on your patient is important. And the pathology, okay, so the bladder, so this picture here, imagine like this is on the outside and this is going inside to the lumen. Okay, so that's what we're looking at. And so the bladder is lined by outside, we've got the fatty layer, then we've got muscle. Then we've got this connective tissue, and then you've got the epithelium. And the epithelium of bladder is called urothelium. Okay, so it's called urothelium. And it lines the entire urinary tract. So even through like the ureters, all the way up to the kidney is the same type of transitional or urothelial epithelium. Now, what happens in bladder cancer, the most common one, the most common type of bladder cancer is still this urothelial type. So it's the same type of cells that you normally find in the bladder, but they become abnormal and they become dysplastic. And it eventually can give rise to, this little tumor here. And they tend to form like little projections, or they're called like papillary tumors. So that's important to know because different risk factors give rise to the different types of bladder cancer. And less commonly, we have called squamous cell carcinoma and we have adenocarcinoma. These ones are less common because, again, the normal epithelium of bladder is transitional epithelium. And these end up being, a different cell type, a different epithelium. And so risk factors for these are like chronic inflammation, having chronic like UTIs, chronic kidney stones, again, this schistosoma infection I was talking about earlier. What that does is that changes this normal epithelial lining to a different type, squamous cell, and then that becomes dysplastic, and then you get that kind of cancer. And it's pretty much the same with adenocarcinoma. Adenocarcinoma, it's like glandular epithelium. They have lots of glands. Again, that's not normally found in the bladder. So these two are a lot less common. But takeaway, most common is urothelial carcinoma, and it arises from this same type of normal epithelium that we have lining the bladder. And this just shows like the little papillary tumor that it would look like, invasive papillary carcinoma that's coming in and invading the tissue. Bladder cancer staging. So does everybody know the difference between like stage of a cancer and grade of a cancer? Stage and grade? Or does anybody know what stage means? So stage is not super sure. Yeah, no, yeah, that's fine. So stage is the size and the spread of the cancer, okay? So cancer that is defined to the epithelium. So if we go back and look at this, it's defined to the epithelium right here. That would be carcinoma in situ. So it's not technically cancer yet because it has not invaded the basement membrane. Once the cancer invades and those dysplastic cells invade, that's when it becomes cancer. And when it continues to spread, you know, to the muscle especially, and then out into the lymphatic system and then to other organs, obviously your stage is going to increase because stage is indicative also of prognosis. The higher stage you have, the worse prognosis. Again, that's because, you know, if these cells have invaded the basement membrane, they've made their way all the way into the muscle, you know, we're concerned, right? They've traveled a long way. They're probably going to keep traveling. And so that's what stage is it tells us like how far has the tumor traveled, like size and spread of the cancer. So for example, we'll just look at some of these here. Stage 2 and above for bladder cancer specifically is known as muscle invasive bladder cancer. So again, once the tumor has spread into the muscle, it becomes stage 2. Everything up here, like when it's just inside the connective tissue and lamina propria, that's not T2 yet. That's still T1 and stages below that. But once we get to the muscle here, we get T2. And it's important to get a good specimen on pathology and on biopsy because you want to make sure that you see muscle on whatever sample you have, because you need to know, is the tumor spread into the muscle or not? Because if it is, then that changes the treatment, okay? The treatment's a little bit different for whether or not it has invaded into the muscle or if it has not invaded into the muscle yet. And so that's why we divide bladder cancer into muscle invasive and non-muscle invasive. And again, the treatment for both is a little bit different. So does our patient, so where did I say? I think it's back here. Nope. Yeah, I didn't. Anyway, so our patient has cancer, I guess on pathology. I thought I was going to put this on the slide. I apologize. So let's say on pathology, our patient had cancer that has spread to the lamina propria. Okay, it has spread to like this connective tissue area. Does he have muscle invasive or non-muscle invasive bladder cancer? And you can use this diagram to kind of help you out. So we have our guy's tumor has gone from the epithelium and it's made its way into like this lamina propria area, connective tissue area. So yeah, non-muscle invasive, great, wonderful. Yeah, so we started near the lumen here, near the epithelium. We've invaded the basement membrane, which is why he has cancer, and he stopped at the lamina propria. His has not gone into the muscle yet. So that has a better prognosis, you know. So briefly going over how we would treat him. So this is a very overwhelming picture, but we're not going to talk through all of the details. I think just in general, it's important to know if you have non-muscle invasive bladder cancer, usually you just do the TURP therapy like we talked about, grabbing the tumor, sending it off to path. And then the only thing you have to do after that is give them this therapy with BCG. BCG is a bacteria, essentially. It's made from the strain of Mycobacterium bovis. And what it does is just it elicits an inflammatory response within, the whole mechanism is not entirely understood, but it elicits this inflammatory response within the bladder, and it helps to kill off any of those residual cancer cells. And so patients who have non-muscle invasive bladder cancer will have that therapy for a while, and that's usually it. Now, if they have muscle invasive, we need to be, a little bit more aggressive with what we do. Sometimes they will give what's called neoadjuvant chemotherapy, or that is chemotherapy before we do the procedure, right, to remove the tumor, etc. So they might get something like cisplatin, and these are all like chemotherapeutic drugs. And then they might do the surgery, remove the tumor, and then you might get radiation and or chemotherapy after that. So you can see how it's a little bit different than the non-muscle invasive, where they just get this, bacteria. The important thing to know here as well is that with both types, you need surveillance with cystoscopy. And this goes back to why bladder cancer tends to recur. So the reason we need to keep surveilling these people, even after they have been treated and even after their cancer has gone away, is because new tumors can arise. And the reason goes back to that urothelial lining that the cancer started from, the dysplastic cells. It lines the entire urinary system, right? And so if you have mutations in that, it could be anywhere. And so that's what's called like a field defect. The mutations don't necessarily have to just be in that area that you had that first tumor. You might have more mutations in different areas that just have not progressed enough and have not formed a cancer yet. So this is why a lot of times patients will have, a tumor pop up, you treat it, and then, years later, they have another tumor pop up. So that's why it's really important to do surveillance with cystoscopies. What this looks like is like, for the first 6 months or something, maybe you get a cystoscopy every 3 months. Again, I'm making up numbers. It's just something around that. And then like the next 2 years or the next year, it's like you get it once every year. And then you eventually go to like once every 2 years. So again, it's not one of those like one and done deals. You have to keep paying attention because these patients are at high risk for developing a cancer at a different point. These are my sources. So what's next? This one is a little bit of a faster session, I guess. There is a 10-question quiz. I think you guys will enjoy doing that and kind of testing what you've learned from this session. Does anyone have any questions about bladder cancer? This one was more of me like lecturing than asking you specific questions. So I apologize for that if that was less of your style. But again, I hope it helped you to get some like a framework for one of these chief complaints that's really common, and also something that I think is really important, because many times I think it's easy to run across these like incidental findings, like the microscopic hematuria, blood on urinalysis, and to just let it go, right? And not work it up. And that's dangerous because, our patients could have, bladder cancer or something like that. And that's why it's really important to be diligent about working up certain things. And so if anything, I hope you take that away, is if you ever have a patient and they have microscopic hematuria, you need to, follow the algorithm and do something about that.